Hi, this is Iosif Xenogiannis and Manos Brilakis from the Minneapolis Heart Institute and the Cardiovascular Innovation Foundation, presenting case 51 for the manual of PCI. This is a case illustrating complications of acute myocardial infarction. The patient was an elderly woman who presented with a non-ST segment elevation myocardial infarction. She had multiple risk factors, and on presentation, her ejection fraction was 30 to 35% with anterior and apical hypokinesis and akinesis. She was taken to the cath lab, where she was found to have a significant lesion in the proximal to mid LAD, close to the takeoff of a fairly sizable diagonal branch. It was a left dominant system with a large circumflex supplying the inferior wall of the left ventricle. As expected, the right coronary artery was small and not dominant without significant disease. Therefore, the culprit lesion was the LAD. Given the lack of severe disease at the ostium of the diagonal branch, a decision was made to perform provisional stenting from the LAD proximal to the mid LAD, jailing the diagonal, and to ensure we didn't lose access to the branch, a workhorse wire was placed for protection. A 275 by 28 millimeter stent was placed across the origin of the diagonal branch, and that provided a nice result with TIMI3 flow into the LAD as well as preserved flow into the diagonal branch. The patient did well after the procedure. However, the following day she had sudden onset of right arm and right shoulder pain, and then she went into PEA arrest, requiring emergent intubation and cardiac compressions with the Lucas device. At that time, an emergency echo was done at bedside, demonstrating a new pericardial effusion, which obviously is worrisome for left ventricular rupture. The patient, under ongoing compression with Lucas, was transferred to the cath lab and placed on ECMO. You can see the 24 French venous cannula. And then left ventriculography was performed, which was extremely revealing because it shows filling not only in the left ventricle as one would expect, but also there is immediate filling into the right ventricle. And then if you follow the contrast travels all the way around and fills into the pericardium. So what we have here, it's a ventricular septal rupture. There is a new VSD, presumably due to the myocardial infarction, but not only that, there is free wall rupture as well, which explains the contrast going into the pericardial space. This is obviously a high-risk situation. The patient was emergently seen by cardiac surgery. Pericardiocentesis was done, removing bright red blood. However, due to her frailty, she was turned down for cardiac surgery and subsequently died. So this is an example of a ventricular double rupture, which is a rare complication of myocardial infarction, less than 1%, 0.3% in the fibrinolytic era. Risk factors include increased age, female gender, hypertension, large myocardial infarction, and fibrinolysis. Our patient was a woman, was elderly, did have hypertension, and she did have a large anterior myocardial infarction. The echocardiogram was actually not very useful for confirming the diagnosis here, which is often the case given the patient's PEA arrest and lack of normal circulation. And this situation does have high mortality given the large extent of myocardial infarction. The only hope for survival is for emergency cardiac surgery, but of course that requires that the patient remains a surgical candidate, which was not the case in our particular patient. So double ventricular rupture, rare complication of myocardial infarction, and is often lethal. Thank you.